Get started. Our next speaker is Dr. Paul Sondel. Dr. Sondel received his bachelor's degree from University of Wisconsin-Madison, along with his PhD in the Department of Genetics. He received his MD at Harvard Medical School. He was a postdoctoral research fellow at Harvard and did his internship at the University of Minnesota Hospitals and his residency at the University of Wisconsin. He has a long career in the research community, focusing on immunology and neuroblastoma and other childhood cancers. He's been on numerous committees, including positions within the NCI. His talk today is entitled Immunotherapy for Neuroblastoma, How It Was Developed, What Its Impact, and What Its Future. Dr. Paul Sondel.
Thanks very much, Pat, and thanks very much to all of you. It's a privilege to be here to talk with you, parents and families of children with neuroblastoma. All of us are looking for hope, for better answers. In 2023, we're doing so much better than we were 10 or 20 or 30 years ago. But all of you here today know that we need more progress, and you're looking for better answers. And I can assure you that the cancer research community is working hard to try and do that, in part because of the incentive that you're all providing us, particularly your children. I want to thank Pat for inviting me. I've known Pat for decades now, and what she's doing with this organization is really remarkable. It's a real service to this community. So thanks, Pat. And this is one of the longest titles in the program today, and I want to thank Pat for that as well. She suggested that I try and cover all of this, so I'll do my best in the time that we've got. First, I want to point out a disclosure, and that is that I am not paid by any drug company. I don't have any financial disclosures of payment, but I am an unpaid advisor for a company in Madison that we've helped to develop an antibody together with, and that company is called Invenra, and they're providing some research support to my laboratory in addition to support we get from a variety of other funding agencies and grants. And I'll be mentioning today some of the work we're doing with that antibody that we're developing. So starting from the ground up, why immunotherapy? It's hard when you're talking about children with cancer to try and take how we're doing and put it in the form of hard, cold facts and statistics. But science needs to take the emotional field of childhood cancer and make it scientific, and look at how we're doing, and look at when we're doing better, and look at when we're not. And so this is a curve that shows the statistics of how children have done diagnosed with all of these different kinds of cancers. Each line is a different kind of childhood cancer. And you can see that back in the 1940s and 50s, very few children with cancer were living very long at all. But particularly from 1970 through 1990, we saw through the work of collaborative cancer treatment organizations like the Children's Oncology Group and others, based on strong laboratory work testing multi-drugs together, we made a lot of progress in treating many kinds of childhood cancer, including some progress in neuroblastoma. This is success, but it's not the success we're looking for. We clearly want and need more. Too many children in 2023 still are not being cured. And our improvements using more chemotherapy with surgery and radiation therapy for many diseases seem to have plateaued. And giving higher doses of those drugs isn't getting us the benefit that we necessarily would like, given the toxicities associated with it. And even for those children that are being cured with today's therapies, many of them are undergoing short-term toxicities of nausea, vomiting, other issues, as well as long-term effects on their heart function, their growth, their neurologic and emotional function, as well as some children that are treated with all of these drugs are at slightly higher risk for developing second cancers early on in their adult life. We clearly have to do better. In order to do so, we think we need something in addition that's different. So most children while they can have remission from the drugs that they're getting, namely, you get them to the point where the cancer seems to have gone away, the sad thing is for too many of those children, there's still a microscopic amount of cancer that's left behind that you're not able to see with an X-ray or a clinical exam. But it's still there in small amounts, and because it's still there, it means it's probably resistant to the therapy the child's received already. So we want to try doing something separate in addition to or instead of that in order to try and get at that disease. And the approach that Pat asked me to talk about is one that I actually started studying back when I was a sophomore in college at the University of Wisconsin in 1969. I had the good fortune of starting to work in the laboratory of Dr. Fritz Bach, who was the pioneer who did the world's first successful bone marrow transplants, which ended up becoming a mainstay of treatment for childhood leukemia. And the way they work is the immune cells from the bone marrow attack the leukemia and keep the leukemia from coming back. It's called the graft versus leukemia effect. So the hope was maybe we could use that same sort of effect to have an effect on cancer. So everybody here knows what the immune system is. It protects you from bacterial infection and from viral infection. In the last century, the advances from vaccine immunology has wiped smallpox off the earth for the most part, has made polio a very different kind of thing to think about than it was back in the 1950s. But the immune system can do bad things as well. There are diseases where the immune system is starting to attack normal tissue, diseases like diabetes or multiple sclerosis or rheumatoid arthritis. But if the immune system is doing something that you don't want it to do, it's because it's attacking normal tissue, or for patients that might need a graft of an organ from someone else, like someone who needs a kidney transplant. Their immune system will reject every kidney that you transplant into them unless it's from an identical twin or unless you give them potent drugs to suppress their immune system. So the idea behind immunotherapy is, could that same immune system that can reject a kidney be turned against someone's own cancer? That's the idea. And there's been real progress. We got a long way to go. And I said, I've been working on this since 1969. So here's a picture that one of my patient's parents showed me a couple decades ago that they saw in National Geographic. They were reading an article on immunotherapy, and it's a great picture because what it's showing here are white blood cells sticking to and killing cancer cells. And you can do a lot of things to white blood cells, and there are a lot of different kinds of them, and we won't go into the specifics of which kinds, but those white blood cells can get activated and stick to the cancer and kill it. And we can make this happen in a test tube. That's what we're looking at here. You can make it happen in mice, and we can make it happen in patients as well. But the real challenge is, what is it that the white blood cell has to see on the cancer to know that it's cancer, as opposed to know that it's not your normal tissue? Because the cancers that arise in a patient, unlike a foreign kidney transplant, those cancer cells came from their own cells. So they're self cells. And in order for the immune cells to see something different so that they can destroy the cancer, not the normal cells, that's the real challenge of the immunotherapy. So here's a graph showing how poorly patients with advanced melanoma were doing back about 15 years ago. These are patients, adults, that have advanced melanoma. It means that their disease has already metastasized at the time of diagnosis. And you can see when these patients were getting the best first or second line chemotherapy available for them. Sadly, it looks like every patient is dying in roughly a year. This is terrible. Clearly for melanoma, we need to do something better. So nothing was making a difference for those patients. So this is a disease where immunotherapy has made a big difference. So one of the main concepts in immunotherapy is there's a certain kind of an immune cell called a T cell. How many of you ever heard of a T cell? All right, great. I didn't know what to expect. So if I'm doing this too remedial, wave your hands and I'll make it a bit more scientific. But T cells are able to see foreign cells because they have a molecule on the surface that the T cell can see as a target. It's called an antigen. So T cells can see melanoma cells because of a melanoma antigen, and that should turn this T cell on to kill that cancer cell. The trouble is the cancer cell doesn't want to be killed, and it expresses a separate molecule called PD-L1. That molecule interacts with a separate molecule on the T cell, and it turns the T cell off. It puts the brakes on the T cell. So even though this T cell has the machinery to be able to recognize and kill the melanoma, the tumor has figured out how to put the brakes on that and prevent that from happening. And so in order to stop that, if you put something in that gums up that brake, that blocks that brake, the PD-1 receptor on the T cell, so that it's not getting turned off by this signal, now this T cell can kill the melanoma cell, and it works clinically. And this is a separate clinical trial for adults with melanoma that are getting that kind of take-off-the-brakes therapy that some of you may have heard of. It's called checkpoint blockade, immune checkpoint blockade, like ipilimumab or nivolumab. And these are adult patients with melanoma. And what you're seeing here, this 0 means you measure how much melanoma the patient had at the time they were diagnosed. And you then measure from that time to what happens after you treat them with this checkpoint blockade. And if the tumor grows from baseline, you see growth here in percent. And if the tumor shrinks from baseline, you see it shrinking. And look at how 3/4 of the patients with melanoma have the cancer shrinking. Over half of them have the cancer shrinking more than 75%, and about 1/3 of them have the cancer going away entirely. So this is clearly game-changing, and it's all being done through the immune system. The drug doesn't do anything to the cancer. It only acts on the immune cells so the patient's own immune cells can recognize and destroy the cancer. So here's how different that survival curve looks. Compare this to the one I showed a few slides ago. These are melanoma patients that are getting this combination checkpoint blockade, and at least in some trials, it looks like 40% or more of those patients are having the melanoma go away and not come back. It's a game changer. And based on that, the people who really devised this therapy in the laboratory, Drs. Allison and Hanjo, won the Nobel Prize in 2018 because between 2010 and 2018, it was clear that this approach was making a huge difference for at least some patients with cancer. How does it work in kids? Not well at all. Here's the sad truth. This is a paper that was published by colleagues of many of us that are here today. 55 children with advanced pediatric solid tumors were treated with the same drugs that I just showed you doing so well to treat patients with melanoma. And of those 55 children, none of them had the cancer go away. Only 2 of them had the cancer shrink. All the rest of them had the cancer grow or not shrink at all. So this is so incredibly different from what we see with melanoma. Why? What's so different about childhood cancer? So this is a complicated slide, and I apologize for the complexity, but I want to explain it because it's important. What you see along the bottom here are the names of a variety of different kinds of cancers. This is melanoma. These with the red boxes are the childhood cancers. Above each box where the disease is, you see this line of dots. Each dot is a patient. And what you're looking at is the number of mutations that that patient has in their cancer. Liz talked in the last talk about how mutations are important in cancer. We want to understand the genetics. So this is telling you how many mutations there are in melanoma. This is on a logarithmic scale, so each one of these ticks goes up by 10-fold. So what this is in essence telling us is that melanoma patients have 10 to 100 more fold mutations, 10 to 100 times more mutations than children with cancer. It's because what drives children's cancer to be cancer is different than what makes adult cancers be cancer. And there's many fewer mutations in the childhood cancers, and it's those mutations that let the cancer put something on their surface, the antigens that the T cells can see. So if you don't have very many mutations, you're not going to have antigens that T cells can see, and that's why checkpoint blockade doesn't work. So we need something different. So if there aren't enough antigens and your own immune system isn't going to see something that it can recognize and destroy, what options do we have? And we've got some good options. One is what we call synthetic immunology. What I mean by synthetic is it's not something your body's own immune system is making on its own, but it's something that you have to make in the laboratory with intention. So back in the 1970s and 80s, the first work on this was done taking human cancers, immunizing mice with it, purifying the immune cells from the mice that made the antibodies, growing those up in bioreactors and making something called monoclonal antibodies. How many of you heard of monoclonal antibodies? Okay, so that's the history of monoclonal antibodies. You can make thousands of monoclonal antibodies and then screen them, and looking for a needle in a haystack, find one that might bind to a cancer cell but doesn't bind very well to nerve cells or to other normal cells. And that's how the anti-GD2 antibody was identified, and we can use those kind of antibodies to help make an effect against the cancer. And here's how they work. This is a picture of a cancer cell, and it's got molecules on it that can be seen by an antibody. And if you make an antibody that can see those molecules, the antibody will stick to the cancer. That's good, but nothing happens. The antibody just sits there on the cancer cell still lives. In order for the cancer cell to die, you need white blood cells that have these orange things sticking off of them. Those are receptors that let the white blood cell see the antibody, stick to the cancer cell, get really tight and cozy with that cancer cell, and then pour into it molecules that the white blood cells use to destroy tissue and kill the cancer cell. That's called antibody-dependent cell-mediated killing. And that's how virtually all antibodies that act against cancer cells work. Here's a picture of it working. This is from our laboratory. What you see in this picture are all of those cells that look gray. Those are actually white blood cells sitting in a test tube, and that red thing is a spheroid of neuroblastoma cells that is sitting with the white blood cells that aren't doing anything because we didn't put an anti-tumor antibody in. Here's the same thing over on this side, where the same size tumor nodule was put into the white blood cells, but we added the anti-GD2 antibody to it, and you can see the cancer is completely going away because the white blood cells are killing it. So I skipped the slide, but it's just a picture of high-risk neuroblastoma. Let me try backing up. Do I push the bottom button to back up? Works, thanks. Okay, so my anticipation is that many of the families that are here because you've got a family member that has high-risk neuroblastoma. And that high-risk neuroblastoma is the disease that, at least up until 2009, immunotherapy wasn't proven to make a difference, and we were helping many children, but not nearly enough. We've got to do better. And so in order to do better, we've taken what was the standard regimen for neuroblastoma that you're familiar with, many months of multi-agent chemotherapy together with surgery and stem cell harvest, followed by an autologous bone marrow transplant or two, followed by some maintenance therapy using an agent called cisretinoic acid. And this very complex regimen was being used, and it was getting the kind of results you saw on the last slide. But the next step was to take this anti-GD2 antibody that was identified by the processes I showed a couple slides ago, and a number of researchers around the world were involved in testing and developing anti-GD2 antibodies and determining how to test them and what to give them within patients, and we were working on this in our lab as well. And based on this work, the Children's Oncology Group tested this anti-GD2 antibody we now know as dinutuximab in a randomized trial. Children were given their induction therapy, then they were given their autologous transplant, and if they were in remission, then they were randomized to either get the immunotherapy with the GD2 antibody or not. And you could see that there's a clear difference. The patients that got the immunotherapy had a much greater chance that our statisticians told us was real of staying without any disease as long as they got the antibody. Well, that was good, but too many patients didn't even qualify for this because they weren't in remission. And even those that were in remission and got this therapy, 40% or more of them are still having their disease come back. So here again, we need to do better than this. And what's the next step? So this was our next step as far as the standard of care for neuroblastoma therapy, including the anti-GD2 antibody in this remission maintenance phase. But the next was to take patients that had already relapsed. And at the time that this was done, a COG study led by Raj and Modi, 2 drugs were being contemplated as helpful for neuroblastoma, chemotherapy called irinotecan and one called temozolomide. And so COG did a randomized trial giving patients with relapsed neuroblastoma those 2 drugs, either together with a third chemotherapy called temsirolimus or with the anti-GD2 antibody. And here's the curve, and even though the number of patients put in this was small, you don't need a statistician to tell you that the ones that got the antibody were doing much, much better than the ones that got the third drug instead. For those patients that got the third drug, only 1 out of 18 patients had a transient shrinkage of the cancer. While for the ones that got the antibody, 8 out of 17 had either a partial or a complete shrinkage of their cancer. And this shows that they were maintaining a pretty long event-free survival, and some of these patients have not had their neuroblastoma come back. Well, that was pretty exciting, and based on that concept where the drug was working together with chemotherapy, St. Jude asked, might it make sense to not only give this antibody when the patient's in maintenance after getting the bone marrow transplant, but what if the antibody was used in the beginning together with the chemotherapy, since that seems to help if you give it to patients in remission. So this was a study done at St. Jude, co-led by Sarah Frederico, who you heard from this morning, together with Wayne Furman, and the results were really very exciting for the neuroblastoma community. This shows that if you start this anti-GD2 antibody, it's a slightly different antibody called this, and you look at those patients that are alive without any cancer coming back, that's what's being shown in blue, they're doing really well, and this is starting at the very day of diagnosis. Unlike the COG trial that I showed you before that had the drug started, the drug shown here was started only after they'd gone through the induction and the bone marrow transplant. So this St. Jude data is really very exciting, and we're now in the process through the COG asking this question to all COG neuroblastoma patients in a randomized trial, and this is being led in part by Sarah Frederico, and she probably went through this earlier this morning. Sorry I didn't get here for it. So in all of these trials that I've talked with you about where the anti-GD2 antibody is making a difference, our laboratory got blood samples from the patients and looked at how much of the antibody was actually circulating in the blood of the patients. And what this graph shows, this shows those patients that had their cancer shrink early in the St. Jude trial after 2 courses. And these are those patients that still ended up doing well, but their cancer wasn't shrinking after the first 2 courses. And each dot is a different patient, and what we're showing is how much of the antibody was in their blood. And even though we gave the same amount of antibody to each patient based on their size, some patients have more antibody circulating than others for reasons that we're not completely sure of, but this says that those patients with more antibody are doing better. So based on that, we've looked at other trials and seen the same thing, and these other trials suggest if we could give more of this antibody, maybe we could get the patients to do even better than what we've got going on now. And one of the best ways to get the antibody level up higher would be to give more antibody. But we don't give very much of this antibody. The amount of this anti-GD2 antibody that we give to neuroblastoma patients is this much. It's 17.5 milligrams per meter squared. That's how we measure it. It works through that antibody-dependent killing process. These are 2 other antibodies you may have heard of that are used to treat lymphomas, or antibody that's used to treat adult head and neck cancers and certain other cancers. They work by the same process, that antibody-dependent cell killing. The doses that we use of those 2 antibodies are 20 times higher than the dose that we use of anti-GD2 antibody. Why? If more drugs should make the antibody work better. And the reason is that we know the anti-GD2 antibody causes this neuropathic pain. It causes pain in children that get it, and I know that many of you have had this experience, and I've had many parents let me know that through the whole course of their child's neuroblastoma therapy, for at least some of those families, the most difficult thing for them was to be watching their child get the GD2 antibody because of the pain associated with it. So why is it that they've got the pain? And the reason is this anti-GD2 antibody has the good anti-tumor effects it does because this antibody sees these red dots, which are the GD2 molecule that's expressed on virtually all neuroblastoma. The trouble is nerve cells have some GD2 on it. Much less, but they still have it. And because of that, This antibody can kill the neuroblastoma, but it sticks to the nerve cells, it irritates them, and in some cases it even kills some of those nerve cells. So we want to try and do something better. And where we're going is an approach to try and decrease that pain that's associated with the anti-GD2 antibody. We want to try and make it more tolerable, be able to give it as an outpatient, and maybe even increase the dose of the antibody that we can give. So Amy Irby in our laboratory has taken an anti-GD2 antibody working with this company Invenra and made it a bispecific antibody. So one end of the antibody needs to see the GD2, and the other end needs to see a separate marker that's on the tumor but not on the nerve. It's called B7H3. So the way this should work is that this antibody will only bind if it sees both things on the same cell. So it should bind to the neuroblastoma and let the cells kill it through that antibody process. But this antibody won't bind to the nerve because it only sees GD2. It doesn't see that other marker. So based on that, we've shown when we test it in the laboratory, this is a complex slide I apologize for, but in essence what we're showing is, just like I showed you with the tumors we were measuring, here we're looking at whether the tumors in the test tube are being killed or not. And if they're being killed, the numbers go down. So here's what happens if we use dinutuximab, and here's what happens if we use the sniper antibody that needs to see both the GD2 and the B7H3. Kills the tumor cells just exactly as well. Next is, how specific is it for cancer? So what we did was take a mouse and put 4 different cancers into it. The one I want you to focus on are the 2 cancers down here. The cancer on the left flank has this GD2 molecule on it that's on neuroblastoma but also on nerves. The one on the right flank has both the GD2 and the B7H3, so it looks just like neuroblastoma but doesn't look like nerves. So we take those tumors, we put them into mice, and then we take the antibody and we put a radioactive molecule on it so that we can look at how well it goes to these tumors in the mice. And what you can see here is when we put the radioactive target tagging onto a control antibody that doesn't bind to any tumor, it shows very low background level on all 4 of these tumors. When we put the radioactive marker on the dinutuximab, it binds to the right and left flank equally well. So this would be neuroblastoma and this would be nerve. But the sniper that needs to see both molecules at the same time only binds to the tumor on the right. It doesn't bind to the tumor on the left. So it looks like it's pretty specific. When we test this as far as how well it helps mice to respond to the immunotherapy, we can take 2 separate kinds of cancers that express the GD2 and the B7H3 in mice, this neuroblastoma or this melanoma. These are mouse tumors, and when we look at how many mice are tumor-free in black after the treatment, we've cured same number of mice with the sniper as with dinutuximab in both of these models. We can then take human tumors and put them into mice that can't reject them, and if we treat them with this sniper molecule, we're also able to get these mice to be tumor-free to the same level as we do with dinutuximab. We then asked a question about pain. It's hard to measure pain in a mouse. It's hard for the mouse to tell you when they're having pain. To save time, I'll just say that mice that are feeling good, if you put them in a cage that has some of their wood shavings beddings in a tunnel, they'll go into the tunnel and they'll want to clean it out and they'll kick all the bedding out. And if the mouse isn't feeling very well, the mouse isn't going to kick most of that bedding out. And so when we do this experiment in a very controlled way and we treat the mouse with either no treatment or an antibody that doesn't bother nerves, like rituximab, they kick out all the bedding. When we treat them with the sniper antibody, they kick out all the bedding. But when we treat them with dinutuximab, they kick out only a fraction of the bedding. So it's clear that the dinutuximab is causing pain that we don't detect when we use the sniper. So here's really the reason why. When we actually look at how these antibodies bind to human neuroblastoma, we take the 2 separate antibodies, the dinutuximab or the sniper, we put them onto the tumor, and then we put a red dye onto the antibody at the exact same concentrations so the conditions are the same. And you can see that the dinutuximab and the sniper bind with pretty equal intensity to the tumor. When we now do the same thing on nerve cells, and I hope you can see the difference, but these are human nerve cells that are binding brightly when you treat them with dinutuximab. And here's how you don't see anything on the exact same nerves when we use a sniper antibody, which is why this antibody shouldn't cause pain, because it's got to get to the nerve in order to cause the pain. So the conclusion from this is that we've got an antibody that seems to be about as effective as dinutuximab. We think it shouldn't cause neuropathic pain. We think we may be able to get higher dosing, and if we can do that, maybe we can even get better efficacy. And our next steps are to do what we need in order to start putting this into the first-in-human clinical testing. We still have some steps to go, but I think we've done all of the lab work that we need to do, and we're excited to be proceeding. So this is where antibody therapy is going. I want to finish with just a couple other slides on other aspects of immunotherapy. So our current and future immunotherapy for relapse disease at this point involves combining the chemotherapy with the anti-GD2 antibody. But there's some other agents that are being used that might help this work better. There's a separate antibody that helps a certain kind of cell called macrophages to stick to the tumor cell and not get turned off. It's kind of like checkpoint blockade that I showed earlier on, but it works on macrophages. There's another drug called anti-CD40 that's being used to help patients with pancreatic cancer and is actually very far along in showing benefits for those patients. Hasn't been approved yet as standard by the FDA, but it's getting there. We're testing that drug that activates macrophages in our mice with cancer, and we're showing that it looks like it's improving the anti-tumor effect when we add it to the chemotherapy with the anti-GD2. This would be something that could go into clinical trials fairly soon. It's an idea that hasn't been tested in patients yet, but we're not far from there. In addition, these approaches may work if we use checkpoint blockade, because the checkpoint blockade might help those cells that make that antibody-dependent killing work better by keeping the natural killer cells from getting turned off. So it keeps the brakes from getting turned off on the natural killer cells. There's a trial available now called the Minivan trial that's combining that kind of approach together with radiation in the form of MIBG. And MIBG is being combined with vorinostat by NANT. All of these approaches are showing what we think looks like worthwhile future work. And then finally is the concept of CAR T cells. And there's a number of different kinds of CAR T cells that are showing promise for neuroblastoma. And I'll just briefly mention CAR T cells, but Andreas Hexy is going to give the next talk and really focus on this. So the whole idea is you create synthetic immunology this way by creating a receptor in your immune cell that lets that immune cell see a cancer cell it wouldn't ever see on its own, by genetically engineering a receptor that lets it see something on the cancer cell. And if you do that right, that can make a real difference for childhood leukemia. It's a standard of care there. And at least in the setting of neuroblastoma, several trials over the past decade have shown borderline benefit. It wasn't as clear. A very recent study coming out of Italy, of Rome, just this spring, seemed to show a pretty significant impact, that for children with relapsed or refractory neuroblastoma treated there, 63% of them showed at least some shrinkage or partial shrinkage, and 36% of those patients were alive without the cancer coming back at 3 years. So this needs to be reproduced at other centers, but it's exciting, and I think we're going to hear more about this idea with the next talk. So I will stop there. I just want to mention briefly, there's a whole lot of people working in our laboratory, in our cancer center. We're collaborating with many people from COG, from our pediatric cancer dream team, from St. Jude, other people we're working with for this, and we're very fortunate to have grant support from a variety of sources to allow us to proceed with both this laboratory and clinical research.
Thank you, Dr. Sondel. Any questions? Yeah, go ahead.
Great.
She can get out.
Hi,
Hello.
Kim.
Hi, Kim.
A couple of questions. I don't even know if some of them might make sense. Can immunotherapy be used as a maintenance treatment?
That's how it's being used now.
But I
through the
mean
COG.
long term.
The answer is yes, it could be, but is it worth it? There are toxicities associated with the immunotherapy, and if you already think that the treatment has gotten rid of all of the cancer, then to continue going on with more therapy is just causing toxicity. The problem, of course, is we don't yet have as sensitive a way of knowing, is this patient that's in remission and doing well, are they still harboring any cancer that's left that's really at a small level where we should be giving them some more therapy and maintenance, versus can we prove that they're really done and we can stop that?
Okay.
So it's a question of being able to measure that right. If we had maintenance therapy that was less toxic than our current anti-GD2, maybe the new anti-GD2 B783 antibody that hopefully will be less toxic, maybe we could use that longer without the toxicity, or if we had some other agent that wasn't toxic, we'd be more willing to keep going. But we don't want to use something that we think might be accumulating toxicity if we're not sure the patient needs it.
And I guess that's one of my other questions, are the long-term effects and the toxicity of extended use of immunotherapy.
We don't really know because
don't
we
really
haven't
know.
extended this therapy for a really long period of time. But I would imagine if there is some neuropathic toxicity associated with it, if we gave it longer, we probably would see more of it. We learned back in the 1970s that maintenance chemotherapy that was being given to children with leukemia that were in remission, they were getting maintenance chemotherapy for 10 years. But it was clear that the therapy was worse than the disease for some of those, and once the therapy was stopped, it was clear that most of those children were cured already and didn't need the maintenance.
Didn't need that, okay. One more question. When or if, when do you think there might be a trial that mimics the adult nutrition trials, like the fiber response to immunotherapy like they did with the adult melanoma patients?
Can you tell me a little bit more about the trial you're
I don't know if I
speaking
could
of?
explain it. I don't know if anyone else has heard of it. It's a fiber, it's a fiber response trial that they used with some patients with melanoma, and how the fiber kind of enhanced or helped with those patients.
So it's an interesting concept that we're learning based on really strong immunologic basic science, that the way your immune system works is influenced by the bacteria that you have in your gut, the microbiome. And I would imagine that the people doing that trial, although I can't say for sure, might be doing that because they think that they're somehow influencing the immune response because of an influence on the microbiome. There's a number of trials going on trying to intentionally manipulate the microbiome. And in diseases like melanoma, where we know it's clearly T cells that are having an immune effect, and it's the patient's own T cells that are turned on and ready to go, then if you could do something to help those T cells be more potent, maybe by manipulating the microbiome in the right way, you'd get some benefit. And I suspect that what you're referring to is something along those lines. At this point, we're not as far in our pediatric immunotherapy to be able to say that the microbiome is having an effect, in part because most of the pediatric immunotherapy is that synthetic kind of response we're talking about, where we're doing something in the lab to help the patient's own immune cells do something they couldn't do on their own.
Okay. Okay. Thank you.
Any other questions? Okay, go ahead, one more.
Hi, I'm Shay from Utah. So I just had a question with like the B7H3. In one of your slides up here, it says it's overexpressed on most pediatric tumors. So, I mean, obviously, it's got the pros of, not having, being expressed on nerve cells. So, cutting down on that pain level. I mean, I think all of us in here that have had a child have dinutuximab, naxitamab, would sing all the praises to not have to deal with the pain that our kids go through. Sorry, oh my gosh. But with that, where it's found on most pediatric tumors, like, is there some way to test for that? Like, rather than just saying, we're going to give, this whole gamut of children B7H3, but maybe only 30% of them actually have that overexpression on their neuroblastoma cells. So only, of those 30%, how effective is it going to be on even on that 30% where the other 70%, it didn't even have any effect because they don't have that overexpression. So going
Yes.
into a therapy in that regard, is there a way to determine that before we even get that far? I guess.
Exactly. It's a great question. So we've actually done that. We've just completed a trial of a separate B7H3 antibody. This is a trial that was conducted by the Pediatric Cancer Dream Team, a collaborative group that's shown on the upper right of the slide. The study's not been published yet, but we looked at a large number of patients with pediatric tumors, and virtually every child with a pediatric solid tumor had B7H3 detectable on their tumor if we had a good immunochemistry slide that we could look at. And I don't want to be specific because I'm not sure I remember the exact number, but it was on the order of 85 to 90% of the cancer cells in those patients or more had B7H3 on them. So it wasn't a tiny fraction of patients who were B7H3 positive, and for those patients that are B7H3 positive, the B7H3 is widely expressed on their cancer cells. But what you're saying is something that we do want to build into the trials, and that is if we can test a patient before we're going to use a therapy that might have toxicity and prove that their cancer cells have the marker that the therapy we're proposing is going to be useful for, we want to do that. And so for B7H3, the test is pretty easy to do. For GD2, the test is a little tougher, but one of the speakers that you'll be hearing from tomorrow, Pat Reynolds from Texas, has developed an assay to do this for GD2 expression that we're trying to build into prospectively upcoming clinical trials.
Okay, thank you so much.
Yeah.
Any other questions? No?
Thanks.
Okay. Thank you, Dr. Sondel. Okay, I'm going to stay down here again. My feet hurt. Our next speaker is Dr. Andres Hexy. He is an associate professor